Hello, everyone. We're still expecting to get a full house. Hi, Brian, and hi, Mono. Welcome to the Cameroon Town Hall edition of today. We are going to have a very important discussion today, and hopefully we will be having other people joining. How's your week been, Dr. Mono?
Oh, Elvis has been great. So it's been a great weekend, and we had a lovely discussion last 2 weeks on the colon cancer screening in Cameroon, and we had a lot of participation from gastroenterologists both in Cameroon and in the diaspora and the way forward. So it's been a wonderful 2 weeks since then. I'm presently in the hospital, so I'm on call. So
yeah, I truly missed that session. I can imagine, only imagine what Dr. Edita was able to do. He's really a trusted authority when it comes to cancer. And that topic was really a relevant topic, you know. Brian, how is it in Nebraska today?
Yeah, it's great. It's been a wonderful weather. I just returned from Atlanta, where it was extremely warm, and came back to Nebraska, where the weather has been really cold. Very cold outside. I don't know how the weather is like in New Jersey, where you are.
I am actually in Colorado, and we had snow all night, like serious snow.
Yeah.
So yeah, just that change in weather. I think New Jersey should be warmer than Colorado today. And how I hear, tell me a little bit about some of the highlights of the meeting last week, Brian. I know we are expecting many more people to join, but just some key things that stood out to you in the presentation last week.
Yeah, the key thing was how he presented a lot of information about how to improve the screening for colorectal cancer. We talked about FIT. We talked about the use of FOBTs in Africa. And in the United States, we have more refined diagnostic possibilities because we can do a flexible sigmoidoscopy. We can do flexible colonoscopy, which can really help you get a biopsy and really know exactly what's going on. But in Cameroon, to my greatest surprise, I realized that we didn't have any of those capabilities, which was kind of concerning to me. But I think with the resources that we do have, we should at least optimize on the use of FITs and FOBTs to at least increase screening. The goal of screening tests is really to find as many cases in the population that exists, and then we can confirm those with more specific tests. So I was a little bit surprised at the challenges, and we were very fortunate last 2 weeks because we had a GI specialist from Cameroon who came and spoke to us about the realities of the field and what the real challenges are. One of the consensus we hope was to come together and have do a comparison analysis regarding FIT and FOBT, or an agreement test. There was sort of discussion whether or not we should do a study or assign maybe a graduate student to do a study to look into the specificity and the sensitivity and specificity of FIT in comparisons to FOBT in terms of diagnostics for colorectal cancer. And as you know, Elvis, the epidemiological curve in Africa is changing very rapidly. So I think that this change from communicable diseases to non-communicable diseases is very apparent. So I think we need to be prepared. We need to build more and more robust diagnostic tools to help us. So I think that was my key highlight from Dr. Ndita's presentation from last week.
It must have been a very interesting presentation. And Brian, I think this is the second time Dr. Dita is presenting on this subject, maybe with a little bit of variation in terms of how we frame the topic. But if I can recall the first time he presented on colon cancer, there was a cutoff age which he advised that for African people of African descent to begin screening for colon cancer. And if my memory is correct, the last time was 45 years. I don't know this time around if the age has reduced based on the changing epidemiology that we are seeing in Africa. Were there some thought around that?
Yeah, he didn't change those. The guidelines haven't changed from his last presentation. It's still the same for the 5 years old as well.
Great. That's interesting. And we really are fortunate to have our presenter already dialed in today, Dr. Alain Abeh, who is going to be our guest presenter today. So, ladies and gentlemen, if you are joining for the first time, this is the Cameroon Town Hall for Healthcare Professionals. It's a platform that brings together Cameroonian healthcare professionals from all over the world. We meet every 2 weeks to discuss on very important health topics that concern our people in Cameroon, and we want to always see how to bring together ideas that can help shape or strengthen our healthcare system in Cameroon. So the Cameroon Town Hall for Healthcare Professionals has been in existence for 3 years now, and we've had 99 sessions. Today is our 99th session. So we are planning to have the 100th session next time. It's going to be a celebration, I'm sure. And we have never skipped any session since we started. And our reach now so far has been about, I think 2,400 people have been able to attend at least one session of the town hall from about 36 countries now. That's the data we can share. So it's always a pleasure to dial in and to see our regulars who tune in every week to every fortnight to be with us on the Cameroon Town Hall. We are very appreciative of the time you take off your weekend to be with us, and we really, really want to thank all those who've been there. I see our own Professor Phoebe Matthias has just joined us. It's always a pleasure to meet you, Prof, and we're always very glad when we see you on the session. So today we shall be talking about access to novel therapy in Cameroon, and this is a very important topic as we continue to see the changing dynamics in the area of therapy and treatment for different diseases across the world. So we have a very knowledgeable presenter today who is going to take us through this important topic, access to novel targeted therapy in Cameroon, unmet needs and opportunities. So it's just not going to focus on the unmet needs. We all agree there will be so many unmet needs, but he's also going to focus on some of the opportunities that he might want us to think about. So I would want to, first of all, before we get into the presentation, just give the opportunity to Dr. Brian, who is the co-moderator. He's going to be co-moderating the session with me to present our guest speaker so you get to know him and why he is presenting this topic. So maybe, Brian, you want to present our guest speaker?
Yeah, thanks. Again, while waiting for others to join, also wanted to, again, really thrilled to have Dr. Alain, Alain with us today, who is a senior medical science liaison. But I also wanted to talk a little bit about some of the recent updates in the epidemiological landscape in Africa. We are, as you're aware, Elvis, we are having recent outbreaks of Mpox in the DRC, which has been a little bit concerning, and also concerning for Cameroon because Cameroon is very close to the DRC. As of today, we have approximately close to 5,000 new Mpox cases that have emerged in the DRC, and that's kind of been particularly concerning. And this outbreak is associated or is linked to a new clade, to this clade called clade 1 of the Mpox. And the reason why we are able to characterize this new variant is because we have next generation sequencing. The importance of next generation sequencing was further amplified during the COVID-19 pandemic, where we were using sequencing to demonstrate new variants and genomic surveillance and how critically it was important for us to find mutations that were important for immune escapes and things like that. So I think next generation sequencing has changed a lot. It has helped to, it has enabled actionable public health in terms of outbreak detection, more precise and more effective outbreak detections. It's helped for genomic surveillance in general, like what we have in the DRC. But I see tremendous promise in the adoption of next generation sequencing technologies beyond infectious diseases, but even into clinical medicine. And the way precision next generation sequencing is being used in precision medicine to advance therapeutics like the novel targeted therapies, which our speaker is going to talk about today, it's really remarkable. So I'm excited about the future, Elvis, and I hope that as a continent we will come together and really leverage the use of next generation sequencing technologies to improve healthcare outcomes in Cameroon, in Africa. It's really critical for us to position us. So the cost of sequencing has reduced significantly. In the early 2000s, with $1, you could sequence approximately 1,000 bases. But today, as I speak to you, with $1, you can sequence approximately 100 million bases. So we are certainly in a better place to generate enormous sequencing data, but we don't have a lot of utility in the use of that data to drive whether it's clinical interventions, new therapeutics, or even actionable public health in that manner. So it's an interesting era that we live in, and I hope that our speaker today is going to enlighten us on the future, what his perspectives are in terms of how this will change the therapeutic landscape, not only in Cameroon, but in Africa in general. So Alain is a senior medical science liaison. He's been working I've known him for many years. I've known Alain for over a decade, and he went to medical school in Cameroon, graduated, and has been working for pharmaceutical companies as a medical science liaison. He started his career working for Mylan. Mylan is one of the pharmaceutical companies that have been increasing access to hepatitis medications in Africa. Africa has been trying to eradicate or at least get rid of hepatitis C. There are several countries in Africa that have been certified as hepatitis C, and he's one of those who've been trying to push for the for access to that particular therapeutics. The name of the drug is sofosbuvir, but he's been trying to advocate for that to be access to that medication to be available in Cameroon and in other African countries where he has worked. So he's really been at the front line of making access to very not only antiviral, but also other targeted therapies for oncology, for GI, for cardiovascular diseases, and increasing those access to some of those pharmaceutical companies that are very costly in the United States or in the West, in Cameroon. So he's done that for several years. He's currently the senior medical science liaison for Nordic Pharma. Nordic Pharma is a pharmaceutical company that's I believe is based in Canada, which they're heavily engaged in the development of immunotherapies and immune modulation therapies, drugs that are very much used in the field of rheumatology. And he's been doing this for several years. So when we thought about someone who could speak to us about how Cameroon can get access to novel therapeutic targets, I couldn't think of anyone better than Dr. Alain. So we are really thrilled. He has an MBA from Western Governors University. He has the other certifications in the pharmaceutical industry as well. So we are really thrilled to have you. Thanks a lot, Alain, for accepting our invitation to be our guest speaker today, and we look forward to your presentation. Alain.
Okay, thank you for the introduction, Tegomo. I'm so happy to be here today. I've been one of the participants in the town hall, and I think that it's making a great impact. We might not know the extent of what we are doing, but I think it's important to maintain the baby steps, and we accumulate that, and then we are able to get greater results. I was very happy when I was asked to do this presentation, because I think it's something which personally I am passionate about, novel therapy. And really it's a problem, because when you're in the field and you're seeing the trends and what others are doing, and you feel that more can be done, it gives a feeling of kind of frustration, because there are opportunities, there are missed opportunities. And the idea of today's discussion is really to look at what is happening from a general perspective, but also to see the opportunities that are there for us to do better as a country. So the topic is access to novel targeted therapy in Cameroon and the unmet needs and opportunities. So I don't have any financial disclosures or interest, and I didn't use any AI assistance to develop the slides. So the objectives of today's discussion really is to understand the global and local trends in novel targeted therapy, understand the burden of access to this novel targeted therapy in Cameroon, and explore or see how we can do more with less, or with what is available right now. So for the plan, we're going to talk about, to see what novel targeted therapy is, look at the global trends, not only in Cameroon, in Africa, and in the world at large. Would see how some of these novel targeted therapies are used in specific specialties, medical specialties, the current management approach, the unmet needs of novel targeted therapy in Cameroon, and try to see how we can do more with less. And then would end this conversation with summing up a little bit of everything that we have said. So basically, what are novel targeted therapies? Novel targeted therapies is really just a very broad term. And basically, targeted therapies are the work by influencing the essential biochemical pathways of mutant proteins, which are required for growth and survival. Since the initiation of or the approval of trastuzumab in the late 90s, there's been a remarkable drive towards novel therapy because of the potential that it presented through treatment of certain types of cancers using targeted therapy in small molecules and monoclonal antibodies, which have really served like a backbone in precision medicine. And this is not only in cancers. It initially was started in cancers, but we see that the use it really cuts across all specialties in medicine. And compared to conventional chemotherapy like we know it, especially those that were used before the 1940s, targeted therapies are very efficient in arresting the biochemical pathways that are at the physiopathology of most diseases. And especially we are looking at immune diseases, we are looking at cancers, we are looking at a wide range of diseases really. And many of these targets are being investigated. They still continue to be investigated in clinical setting. And most of these are just, they still don't have a clinical set or application yet, or approval for clinical use. So we have effectively seen great progress in the use of novel targeted therapy, especially in cancers. We see a bunch of cancers. The image you see on the screen is really just how precise these medications work. In the previous ones, we have seen therapies that are used, and we have a whole lot of side effects, and people end up stopping medication, not using them at all, because they think they are better off without this medication. So in terms of the global trends, novel targeted therapy really it's become clear that this is where medicine is going to. This is where precision medicine is going to. And almost 90% of startup companies in the West, in America and in Europe are investing heavily in novel targeted therapy because they have seen that that's where the money is, that's where the results are, and that's where everybody's interest is going to. And unfortunately, North America really has the bunch of the market. More than 50% of novel targeted therapy is in North America, in Canada and in the US. We also have Europe that is really making a lot of strides, but we see that Europe and all of Africa, some of South America is really still considered as growing markets. This is interesting because unlike what we usually, the perception that we have that all Western countries are advanced, I think that the US especially and Canada are maybe 2-3 decades ahead. And most of the time, these molecules that they get with the patents, the other countries have to wait maybe either they're buying it very expensive or they are waiting maybe 15 to 20 years for the patent to expire before they have access to this medication. So the problem is not really just an African problem, but we see that there is also problem of access in Asia, in South America as well. But these people are making a lot of progress in this light to be able to get the medication, to have systems that work, to be able to allow the patients have access to this medication. And interestingly, the burden of cancers in 2050 is going to double in sub-Saharan Africa. Is there a lot that is done to accommodate this? No. Are there other people that are making strides to have progress? Probably some other African countries are doing better than Cameroon in that light. We have East African countries like Rwanda, like Uganda, that really have national policies to to accommodate medication, to make sure that they are available at the national level. They have registries and all of that. So in terms of Africa, I think that Eastern Africans are doing a lot better than the rest of sub-Saharan Africa. Regarding the treatment in specialties, this is a very broad one because, again, like I said, most of these medications cut across, but I just wanted to give you an overview of the mechanism of action of some of this medication. We have the checkpoint inhibitors, which are really the turn. You have the T cells, it's based off of the T cells. And what they do is they turn on and off the T cells to be able to, proteins, the proteins are called the T cell proteins. And so these medications actually come and attach themselves and prevent either the turning on or the turning off of certain signals that are the cause of diseases. We have a few of the medications there that are checkpoint inhibitors. We have the T cells, and really the T cells are, excuse me. The T cells are a type of immune therapy. I think we are probably light years ahead of this, where really the look at is very precise medicine, where you look at the genome of a disease and all of that. You get a sample of it. You get into the lab. You do cloning to try to adapt it. Multiply some of the antibodies that are working against this diseases or the targets of the diseases. So you have a few of them there. You have the CAR T, and then you have the T therapy as well. I think probably the most popular ones are the monoclonal antibodies that really work by recognizing specific proteins in cancer cells. And each of the monoclonal antibodies recognizes a particular protein. And so different monoclonal antibodies would work for different proteins. And so what it implies is it's important to be able to know exactly the specific antibody which these monoclonal antibodies are going to be working against. And we'll see how it's applied in clinical practice, because if you don't have the capacity to test for the specific proteins, then you don't know which patient qualifies for this medication or not. So we have various specialties in which this targeted therapies are being used in hem-oncology, which is probably the most used branch. I think Dr. Mono is probably going to have a lot more to say about this than me. But in Cameroon, we have leading cancers like breast cancers, which the treatment strategy really includes surgery, radiation, hormone, and chemotherapy. But that in this case, the word chemotherapy encompasses all the available medications that are available for breast cancers before the targeted therapies, medications that were probably available before the targeted therapies. So it uses, there's also a lot of targeted therapy use in breast cancers. For example, monoclonal antibodies that we've mentioned, like the trastuzumab, which is really shown to improve survival and quality of life of patients who are HER2 positive. And so this is the specific protein that it affects. But the burden of diagnosis and the burden of treatment it really stops or it prevents a lot of people in our context from getting this kind of medication. We have other monoclonal antibodies like pertuzumab, which is probably not yet available in Africa and which the patent is not yet released. So, for example, we have bevacizumab that has been used alongside other cytotoxic chemotherapy, very useful in cervical cancers, but we still have a lot of problems with access to bevacizumab, even if there are some patients that make the effort to get diagnosis. But then specifically with cervical cancers, we also see problems with survival related to the late diagnosis, either misdiagnosis or patients that are coming to the hospital later, where there is already metastasis and all of that. We also have rituximab, which is another monoclonal antibody again, is used in multiple B-cell non-Hodgkin lymphomas. Despite the expiry of the originator molecule in 2015, I think, we still see that we've had about 3 or 4 biosimilar medications that have come into the market, but we still have serious problems with access, especially with cost. These medications really, patients have to, either order the medication from abroad, they are sent to them. And so at times it's just overwhelming for them. We have, for example, the 500 milligrams of rituximab still cost about 500 to 600,000. And you imagine a patient that needs to take it maybe every 2 months over a period of maybe 2 years. You have biosimilars which are cheaper, maybe 4 or 5 times cheaper, but then we still find a lot of patients unable to get this medication. Therapies for cancers like chronic lymphoid leukemias are simply unavailable in our context. Although we have some of these medications that are available elsewhere. We have molecules like bortezomib, which is the API for Velcade, used in treatment of myelomas. It costs about 300,000 in Cameroon if we are going to import these medications. Countries like South Africa, like North Africa, Egypt, Tunisia, and all of that, they have national programs where they strike deals directly with these pharmaceutical companies, and then it comes to them less expensive. I'll take the practical example of South Africa, for example, where they say for you to be able to market, or for us to be able to give you our marketing authorization, you need to ensure that we have infrastructure to be able to diagnose these diseases, especially molecular biology, immunohistochemistry. These are the deals that they strike, and then they go into bulk orders, which really brings down this medication, because usually when the patent expires, there is some sort of competition. Even the originator molecule is either they are getting creating another molecule with a different name, but many other competitors get into the market, driving the cost down. And so most of these countries that are succeeding, especially in the South and the North, most of them go by doing bulk orders and then negotiating specific deals to make sure that they have the requirements or the infrastructure to be able to accommodate this new medication. In rheumatology, for example, we have, it's probably one of the most important treatment specialties for targeted treatment in rheumatoid arthritis, SLEs, in inflammatory myopathies, and osteoporosis. In the last 15 years, really, rheumatological diseases has improved. The outcome has improved. The management have improved with the advent of many biosimilar medication. And in RA, for example, rheumatoid arthritis, there have been many cases of new drugs, the tumor necrosis factor inhibitors, the TNFs, the JAK inhibitors that are currently having a little bit of pushbacks now because of the cardiac toxicities. But still then, there is a minimal penetration, especially in the sub-Saharan market. A recent study that was carried out by a Canadian physician, Dr. Carroll, based on the perception of African rheumatologists in using methotrexate in treating rheumatoid arthritis, it really showed that we don't only have a problem of access, because even the products or the molecules that are present in our context, we don't use it enough. For example, in methotrexate in treatment of rheumatoid arthritis, we either have shortages, we have stockouts, and then in cases where they have to give priority, the priority is given to oncology patients than the rheumatoid arthritis patients. And it's shocking because they need usually 50 times less the dose that are used in oncology. So in most cases, they have problems with access, with cost, availability. They also have problems with infections, because we know that it's an immune suppressor. We need to be sure about, infectious diseases around the patient to be able to prescribe them. So those are some of the challenges that are being faced. In systemic lupus erythematosus, whose prevalence is really about 1.5% in young, especially in young Black females. We have steroids, we have methotrexate that are being used predominantly in our context. We don't have any targeted treatments, or even when they are available, they are simply unaffordable for these people. But we see that rituximab again comes in, a monoclonal antibody. It cuts across almost all diseases that you have in rheumatology and immunology. This is a molecule whose patent has already expired for the last couple of years. So I don't think there is any reason today that we shouldn't be having these molecules available in Cameroon. In diseases, for example, like osteoporosis, we have biphosphonates that are being used. Most of the time, they are available. Specialists just have them, prescribe them. Patient access is a whole problem. And I think if we go into the prevalence of some of these medications, it's very present in our community, but then more insight or more resources are put towards infectious diseases. We have medications like methotrexate, again, hydrochloroquine, sulfasalazine, that are being used in rheumatoid arthritis and many other immune diseases, but most of our platform, it doesn't provide for being able to accommodate for this. We have in rheumatology, IBD, inflammatory bowel disease, Crohn's disease, ulcerative colitis. There's this interesting study that was carried out by Dr. Watermeyer in South Africa. It really gives a wide range of reasons why some of these diseases are not taken care of. And usually, interestingly, it is not always about the availability of medication. It is true we have a problem with that, but we have issues with underreporting because we are not sure if it's an infectious disease or if it is actually an inflammatory bowel disease. We have problems with diagnosis, with many of these symptoms that are also mimicked by infectious diseases. We have problems with technical capability, with again IHC dosing and all of that. But we've seen a lot of progress in the South and in the North of Africa in this light as well. We have GI cancers with gastric, hepatic, colon cancers. We really have point-of-care treatments today that they're expensive, but they are affordable. And usually based on my experience, like we'll see it in a few slides, I think that it usually takes just the effort to be able to make some of these things possible. The application of novel targeted therapy in dermatology is also there. Atopic dermatitis, psoriasis, dermatomyositis, scleroderma. When we are doing maybe a clinical medicine, we usually just have the impression that this diseases, we don't see them. But mind you, I talk to a lot of specialists in dermatology, hematology. They see these cases, and most of the time they are just embarrassed because there's just as much as they can do. Dermatologists, the best medication is topical and maybe systemic steroids. They use it across the board. And in a case where steroids is contraindicated, very few cases nonetheless. You also have cases, for example, where a patient cannot get it for other reasons. Maybe the patient has an infection and you cannot give them high doses of steroids. They are not a lot of choices. We don't have a lot of choices in Cameroon. And we have practical examples of things that we can be doing to be able to help some of these patients. So again, in terms of the current management approach, I will not go into details of saying each disease, what is happening at the moment with each disease. But, the idea here is that physicians are using older medications, even when there are newer medications which are affordable in the country. We are still seen a lot of surgeries, total resections, even in cases where partial resections, for example, in the breast, we have lobectomies in the liver and stuff like that. So we still see a lot of systemic or systematic treatment or symptomatic treatment as well. I'll take the example in this case of hepatitis B, where I worked for in a couple of years in Cameroon and in some countries in sub-Saharan Africa. We have this medication, tenofovir. Tenofovir disoproxate fumarate, 300 milligrams, is what has been used for so many years, not only in management of hepatitis B, but also in the management of, it's part of the tri-therapy in HIV. But then in the recent years, we have tenofovir alafenamide, 25 milligrams. It is more, the data is there. It is more efficient. It gives less side effects in the long run because, of course, you're giving far less molecule product itself. But we still see the government requesting for the older molecule, even when we have pharmaceutical companies that are going to bring or that are ready to bring the newer molecules at the same cost. So is it a disconnect between like the scientific body and the decision makers? That we have a real problem with that. So it tells us that we see things that can be done despite the difficulties, but they are not done because of many other challenges that we would see. We have problems with data, we have problems with registry, we have a disconnect between the scientific community and the decision makers as well. So for example, hepatitis C as well, which I work with in Cameroon and in some countries in Africa, we had a pilot project in a few countries in Burkina Faso, Cameroon, Ivory Coast, and it's so disheartening to see that it is only in Cameroon where this project failed. The project failed because we were able to provide test kits to do mass screening for people, but then at the end of the day, the government was ordering different medication. We have, for example, sofosbuvir, velpatasvir, or sofosbuvir, daclatasvir, which are kind of like pangenotypic, meaning that to be able to prescribe this medication to a patient, you don't need to do genotyping to determine if it's hepatitis C, it's maybe from subtype 1 to 4. You don't need to do the genotyping. The genotyping at the time used to cost about 80,000. We brought in a pan-genotype medication, which was going to save patients 80,000. But then we were surprised that, the medication that was still ordered was the previous generation medication, which required patients still going in to do genotyping. So it still brings us back to the issue of are we really doing are we doing the best we can with the resources that we have? In dermatology, again, we have the mainstream treatment, which is used across the board. We have steroids, we have immunosuppressants, which are also frequently out of stock because there is no stock taking. Nobody wants to know what is happening, especially with it's just usually I think that we have more or less a chaotic market where we don't have a centralized body who is really responsible to for taking care of some of these things. There is an interesting study that was done with I've forgotten the name of the paper, but it found that there was more an inventory of chemotherapy medications in Cameroon. A study that was published last year, the inventory showed that about 43% of chemotherapy was provided directly from pharmaceutical companies. The National Drug Procurement Agency, SENAME, had just about 20% of this medication inventory. And then you had patients getting about 14% of the patients were getting the medication either through private pharmacies or directly from maybe relatives that lived abroad. This is a problem because if we need to prioritize targeted therapy or in cancers or every other medication, someone needs to step up to take the lead and say that we are prioritizing this. In a market where we are having about 50% of patients in something as important as cancers going to get to source for their medication from maybe directly from these companies who usually don't even have the marketing authorization in our country I think it's a problem. And I think something can be done in that light. So having seen all of this, what are the unmet needs of treatment in novel therapy in Cameroon? Of course, we can't talk only about access without looking at all the other factors like we've been talking about. We have problems with training, we have problems with diagnosis, we have problems with patient perceptions, we have health policy problems, and of course, we have problem of access itself. In most specialists have the ability to be able to diagnose and treat a whole range of this medication. But then given that we are training, first of all, in a context where we don't see these diseases, we don't see them because we are not doing the test for them. I can assure you, if we're going to go into maybe molecular testing, we would see that we are seeing more cases of inflammatory bowel disease or more cases where we need to use targeted therapy. And so training in the context where you don't have access to this medication just blocks your mind and gives you the impression that you don't have these cases or you're not seeing them. And it's quite understandable because last year I was attending the American College of Rheumatology meeting in San Diego, and I sat with a few rheumatologists from East Africa, from Nigeria as well. After the meeting, I met them and we're talking to them, and honestly, the impression that they gave me was they were completely lost at what is happening because there is a disconnect. What we are or what they are doing now is probably what was done 30 years ago. And usually it's not only about the access to the medication, even when they get up-to-date information about this, what importance is it to them? They don't put it into practice. They don't have the diagnosis. They don't have anything to do with it. So that's why most of the time, Cameroon, Sub-Saharan Africa in general, is just kept at the backstage, and nobody really cares about what is happening there. And I think it's our opportunity, or it's high time we stand up and look at some of these things and see what we can do with what we have available. In terms of diagnosis, again, we have cases, for example, with clinical biologists that are being trained, and there are certain techniques, recent techniques that are being used to be able to diagnose certain diseases that are simply not taught to them by their teachers, because of course the teachers are also not aware about this. Even when some of them train out of Cameroon, particularly in Europe, and they come back, they simply don't put into practice what is happening. We also have a problem of perception. position on the part of the patient, because most of the time we have diseases that we consider rare diseases or diseases that we cannot diagnose, and we just it's a matter of convenience for doctors. Doctors, it's just easy to say that, oh, or on ne voit pas ce qui arrive, ce qui vous arrive, on ne comprend pas. Most of the time when we have those things, we are not helping the patients, because what we are doing is we are reinforcing some the perceptions, especially the negative perceptions about, okay, we have to go back to witchcraft. This is, I went to the hospital, j'ai fait tous les examens, on n'a rien trouvé, but I kept losing weight and things like that. Those are, I personally think that other countries are doing better than us, because for a doctor to tell you that we haven't seen what is wrong with you, it literally means that we have done everything that we can do in our context, but the interpretation on the patient side is different. It means that they have done everything humanly possible and we still can't find what is wrong. And so the best culprit to take in this case is witchcraft. And so I think that we physicians also need to change the way we communicate with our patients in terms of maybe diseases that are difficult to diagnose. Let them know that, okay, with the resources that we have here, we cannot diagnose it, or we cannot say exactly what is wrong. And so it helps the patients. For those that have the means, they can get the treatment elsewhere. We should not be ashamed to propose to patients, you know, different options of treatment. Basically, we have a huge problem with policy as well. Like I was mentioning in my previous slides, where we have, you know, we have a National AIDS Control Committee. We have all of these beautifully named committees, but when you ask yourself, what are they really doing? We have hepatitis committee, we have oncology committee. They are doing a lot, but I think that if we focus on only providing the medication, we are going to miss a huge part of the problem. The problem starts from all of this, from the perception, from the training, from making diagnosis available. And I would tell you people free of charge, a lot of these companies, I've worked with pharmaceutical companies, a lot of them are ready to invest in, for example, IHC. Invest in IHC to be able to sell their medication at the end of the day. Everybody understands that to be able to see a problem, you need to create a need. What we did in hepatitis was we provided test kits to all the participating countries. We say, okay, we're giving you free test kits, screen your patients. When they screen the patients, what happens? We need to provide the means where patients need to do a viral load to follow up on the diagnosis. After the viral load, we need to follow up on the treatment. But now we see a case where people just, you know, it's even ethically wrong to test somebody if you don't have a proposal to make to them. It is ethically wrong. So we can't just dump kits and say, oh, we have given you people test kits, screen yourselves, and then when you have a positive result in Fundong, what next? There is no solution you're giving the patient. You start telling the patient, oh, you need to go to Yaoundé. You can be rest assured the patient is not going to go. So I think that at the level of policy, there is a great opportunity that needs to be used in terms of being able to strike deals with pharmaceutical companies, saying that for us to be able to grant your marketing authorization, you need to make sure that we are providing viral loads to all the 10, I'm just making this up. You need to make viral load available for all the 10 regions in Cameroon. You need to ensure that you're training bringing in experts to do training of this, you know, if it's a particular disease area, you're training this as a give back to you, or our own part of the deal would be to ensure that we are setting up the logistics for you to set up your medication. We're giving you the marketing authorization and things like that. Those are things that can be done at the policy level to be able to help some of these problems. And mind you, most of the biologics or the biosimilars that are available, these companies have money they're willing to invest, but we just make it more difficult to them to be able to help us. So how can we do more with less? We can do more really by prevention where possible. Not all diseases are preventable. There are people that say, I've never drunk alcohol, I've never smoked, but I end up with a cancer, I end up with a lung cancer or a liver cancer. Those are some of those cases where you cannot prevent, but let us try to prevent as much as possible because we know all the problems we have. Let's not try to add our problems. Prevention is very important, not only in cancers, but across the board. We have HPV vaccines that help prevent cervical cancers now. We have, for example, hepatitis B vaccines. We don't have a treatment for hepatitis B, but at least we have a vaccine that helps you prevent some of this. We should really help in our communication, mass communication, making available the early diagnosis. When you're having this problem, when you're having this and this, don't go to your neighbor to ask that when you were in the hospital, what did you take for this? I have the same symptoms. Let people know that they need to go to the hospital. And there are multiple layers of complexity in this, especially in our context where we are not only fighting against misinformation, but we are also fighting against our colleagues on the other side, the traditional practitioners and the pastors who are like the ultimate professors of medicine. They treat everything in the shrines and in the churches. It's a double burden, like I usually like to call it, because misinformation on one side, but then we also have a lot of our practices that are not very helpful to us. We see a lot of patients coming to the hospital at very late stages and really nothing can be done. It's more like you're coming to die in the hospital. Another thing we can do really is to create registries. For a pharmaceutical company, when I'm talking to my colleagues and I say, oh, but why are you not marketing this in Africa? They tell me, okay, what is the prevalence of inflammatory bowel disease or ulcerative colitis or Crohn's disease in Cameroon? Most of this data is not available. It's not available for multiple reasons, but I think that we can start by doing what we can do with what is available at this point. We can start by creating registries, creating a need. This is going to help policy to lobby. This is going to help the scientific committee to lobby to the policy makers, but also it's going to inform potential investors like the pharmaceutical companies to be able to say, okay, there is a real need for this medications in Cameroon. So we have, just to conclude, and we have a few medications here that have lost, their patents have already expired. We have a lot of biosimilars, and we have injectable methotrexate, which is really, we have a project which we're working on right now with injectable methotrexate. I know when we were in medical school, we used to hear about methotrexate only in cancers, but methotrexate really cuts across, and it's not the same doses. It's usually 50 times less the dose in oncology. So yes, methotrexate has a place in many of these immune-mediated diseases, and a simple disease like rheumatoid arthritis, for example, where oral methotrexate is available. We have data here in Canada. It's still the first line therapy for rheumatoid arthritis here in Canada. We still use it, but we don't use the oral form. We use the pre-filled syringes or the auto-injectors because there are studies that show that the side effects that patients get, the GI side effects and all of that, is usually really linked to the absorption through the gut. So we are now using the subcutaneous injectors. We're using pre-filled syringes where we are giving the optimal doses, 25 milligrams, without a lot of fear. People do 20 milligrams, 25 milligrams, and they really keep like the rheumatoid arthritis under remission or low disease activity over a few years before the switch to biologics. Biosimilars are available now, and it's really come to I love to say biologics or biosimilars is the best thing that always happens. The patent usually is about 15 to 20 years. A lot of these medications that you see on your screen are actually, we have a lot of players. We have the Amgens, Apotex, Biocon. We have a lot of them that are doing biologics, which are usually available. And most of the time, the price is not the same. You would imagine the competition. Everybody is trying to get to get into the market. They are not the originators, so they have not spent a lot of money in, RCTs, randomized clinical trials, and so they can afford to sell it at 10 times less the price of the original molecule. But we need to create an environment where people can be able to invest. And to conclude, really, it's really about, from my personal experience in Africa in general, sub-Saharan Africa, we have a serious problem with medication, especially these biosimilars where they are usually kept during at a particular range. They are proteins that can easily be denatured. So we have problems with storage. We see a lot of marketing authorizations delivered to, I would literally just call them fake companies from especially Asian countries. We have medications that cannot be marketed anywhere else apart from Africa. This is because we don't have any, we have LANACOM, we have those bodies, but practically what do they do to ensure that the medications that they are granting marketing authorizations for are companies that have a minimum of standards? We have a lot of companies from Asia, from India that cannot basically sell their medication anywhere else because they are low quality, and they find Africa the dumping ground. So these companies that you see on the board are really, they're mainstream companies. They're companies that are well grounded. Ask yourself, what stops them from coming to Africa? Is it because we don't have the infrastructure? I don't think so. Most of the markets where they go to, the start, their business model is usually to go in or invest during the first 2 years, invest in screening, invest in diagnosis, and then they can hope to start getting returns on their investment at the third on the third years or so. But what we are seeing is when a patient needs a medication, they meet a pharmacist in town, and then the order it from India. They give it at maybe 5 times less the price. Nobody is sure about the storage, about the quality. It comes directly to them. Patients get it. You get well, you don't get well. Nobody knows if it's due to the medication. So it's a real problem. And I think that if, this is my personal opinion, though, I think that if we really need to fight against some of these things regarding like the access to novel therapy and certain therapy, we need to act more serious. Acting serious means that we are attracting more serious companies, because mind you, no serious company, ethically speaking, would sell you medication if they are not sure that you have the right, the right diagnostic tools. Because it's useless to give, for example, trastuzumab to a patient that is HER2 negative. We don't have this infrastructure. If we don't get into testing these patients, then there's no point for us to have this medication, because we would not know who to give this medication to. And so just to conclude, to sum it up, we know that Cameroon is far behind not only the West, but also many African countries. We are far behind the Ivory Coast. Strange enough, even Burkina Faso is doing a lot better than us. We have the Eastern and the Northern countries that are making a real effort in terms of access to novel targeted therapy. Despite these challenges, we see that there is still a window of opportunity. There are things that can be done with what we have now in terms of, we've mentioned, with the diagnosis, health policy, perception, and the kind of messages that clinicians or physicians share with their patients. We have a role of the patients through patient advocacy groups. That is one thing that really struck me, because we have this culture where everybody wants to handle their stuff alone. Most of the approvals or the health policies out in the West is being driven by powerful patient advocacy groups. Imagine if 50 patients that have, for example, rheumatoid arthritis come up and set up a meeting, and then they say, oh, we are writing a letter to the minister to tell him the difficulties that we are having in getting this access. If all the patient groups come together, to set up, in groups and say, okay, we are having problems with this medication. If the scientific community has been saying it and people are not, and the policymakers are not listening, I think patients can do their own part in the treatment. But most of the time, what happens is once somebody can afford for the medication, they don't care about what every other thing is happening, without forgetting that you might not be able to get access to that medication. You might be getting the wrong medication because of a broader policy problem. So we need to really come together in terms of, the patients coming in to try to address some of these issues. For the physicians, we can try to not, reinforce some of those stereotypes in patients. Oh, we've done everything. We don't really see what's wrong with you. I would really prefer you telling the patient that we have done everything we can at our level. There is still some tests that can be done. If you were not in Cameroon, they can be done elsewhere. You always give them that possibility. You have people that can afford it, but once we, the physicians who are supposed to be like the hope bearers for these patients, say we have done all we can, is literally pushing these people towards, other beliefs that are usually very harmful to them. The aspect of shared decision-making is also very important. There are many instances where patients, my dad personally, who is not only about the general lack of education in the general population, but we have situations where doctors don't explain to the patients what is wrong with them. My dad gets the prescription and sends to me, and I ask him, what did the doctor say? He just gave me this to go and buy. There are multiple studies that shows the importance of shared decision-making. Patients that understand why they should take their medication, why they should do so and so tests, are 10 times more likely to do the test than patients who don't understand why they're doing it. Most of the time, they'll think that you're just trying to make them spend money. But if we physicians take more time explaining to patients, telling them that these are the options. If you don't do this, this is what is going to happen. Doing this would mean this. If we explain this model of shared decision-making, I think it really makes a difference. At the level of health policy, really what we should be talking about, like we say, is we should kind of reinforce our quality controls, be sure about where medication is coming from, where it's being used, how it's being stored before we authorize or we deliver marketing authorizations. We have also, as young scientists, we should be more implicated in real-world evidence, real-world data generation. This is going to inform not only the health policy, but also the potential investors that are going to be interested in this. In the context of Cameroon, particularly, we can't be talking about randomized clinical trials, but with what is available, what we can do is we can do stage 4 observational studies where we just see how the medication performs and then report it. It's going to, some of these publications are going to help, to advise decision makers. So thank you for listening.
Yeah, thank you very much, Dr. Alain Abeh, for this really excellent presentation. It's been a really learning session for a lot of us. We see so many gaps, but also a window of hope and opportunity. And if you are joining, this is the Cameroon Town Hall for healthcare professionals. If this is your first time, we meet every 2 weeks to have presentation like this from experts who master the subject matter, like Dr. Abeh. Today's topic was really about access to novel therapy in Cameroon, looking at the gaps and also the opportunities. So it's really been great. One of the things we know is that the town hall has really helped a lot in just bringing to consciousness and to awareness some of these issues, even to the authorities that matter. And we hope that people like Dr. Alain will really work closely with the town hall to see how some of those really great suggestions can be tabled to some of the people that are decision makers, especially in the field of supply chain management in Cameroon for medication. So, Brian, I think it was really a great conversation. I'll hand over to you for a question and answer session.
Yeah, thanks a lot. And if everyone has any thoughts or questions, please feel free to use the chat feature to drop those questions. I think there were already a few questions in the chat, or you can also raise your hand, and then I will try to call you. Elvis, I thought this was quite an interesting presentation, and thanks a lot, Alain, for providing us with a very broad and comprehensive view of what the key challenges are in Cameroon in terms of access to targeted therapy. I think you highlighted multiple issues and challenges that we have, just from even diagnostics capabilities itself to the need to engage policymakers, as Elvis was talking about, how to connect the scientific community with actual policymakers to help bridge some of those gaps. So thanks a lot for shedding light on this issue, and I really hope that one of the transitional applications, at least one of the things that would happen as next generation and new diagnostic technologies become more and more prominent, that we will be in a position where we can adapt some of these new technologies to improve first access to diagnostic capabilities, so we're in a better position to treat our patients correctly. So thanks a lot for your presentation. I also just wanted to give a chance to Dr. Mono to greet the town hall. I know you're busy and you're on call, but I just wanted to welcome you, Dr. Mono, if you have any thoughts from the presentation.
Wow, it was an excellent presentation and geared towards policy. And if you're living in an environment where you prescribe these medications a lot, you turn to really want to have pity for patients who are back home. And each time you're reflecting about how do we get the medications and the advantages that patients here do have in Europe, in the US, in some countries in Asia, bring it back home to Africa. As you said, Brian, technology is moving. COVID did a lot of good things. It gave access to, it actually brought us more than 20 years advance in terms of diagnostic technology, which we need. I always go back to the breast cancer story. Why? Because the breast cancer story is really a highlight of how much our training, our policies can be so backward that it takes us 40 years back. Because in breast cancer, we have known since the late 70s that we could test patients for estrogen and progesterone. We have known since the early 80s that we can test patients for HER2 and it's driving the cancer. We know that. The question is, why don't we do it? Or why don't we have infrastructure in place just to do those basic things? That's IHC, to be able to do immunohistochemistry for all our patients. In the world where we are right now, you cannot boast of treating a breast cancer patient without knowing these basic things. I've always said there are times as clinicians, either physicians, nurse practitioners, nurses, specialists, we do more harm than good, but we don't even know it, that we're doing harm. Neither does the patient even know it. Why does the patient not know it? Because the patient doesn't know better. Neither do you even know better, you the physician. If all patients who are having breast cancer in Cameroon in the first line with metastatic disease are getting chemotherapy, do they even need it? If they are metastatic, do they need it? Did we even do a hormonal testing in the first place? Do we know their hormonal status? We still don't know majority of the cases. And once you don't know that, you cannot use any form of targetable therapy, even basic hormonal treatment to treat them. Where we practice in the US or in Europe, we have left that already. Those are basic things everyone knows has to be done. And we are the transition of doing next generation sequencing. So if we are not able to do the basic things, how do we get to an NGS? Because if you don't know, you cannot even use targetable therapy. You cannot use precision medicine. You cannot use immunotherapy because you don't even know if the patient will benefit or not. For a cancer like lung cancer, which is not very frequent in Africa, we don't even have prevalence and studies, but we don't smoke as much as those in the West. An example, in adenocarcinoma of the lungs, we have approval for more than 20 different targets. I'm not talking about the drugs. Some like EGFR have more than 10 different drugs that we can give patients where they don't even need chemotherapy. And almost 50% of these patients have a target. And Alain's presentation was broad, and it captured all the different specialties with, I'm not just trying to boast about oncology. Oncology is the mother of precision medicine, okay? We are light years away from, if we can talk about this for days and days, you'll not even believe it. Oncology is light years away from any other specialty in medicine when it comes to precision medicine, light years, meaning that we have more than almost thousands of targets and treatments that are available in oncology. So we are light years away. Other specialties are learning. Rheumatology is picking up. GI is learning a little bit. And infectious disease is still at the infancy of understanding and using targetable therapy. But this is something that Africa needs to wake up and be at the table where these discussions are had, because you really get to see that patients are actually at the detriment of everything that is happening right now. Our governments, we need investment, we need to prioritize, we need research. So Alain, I loved your presentation. It went into all of these things. And what is very important that you said, which people are always shy to say, we have excellent, intelligent people who can understand anything no matter where they are, but they are not just taught. If their professors are also archaic and they're not updating themselves, so they too, because we don't have a system of update in Cameroon, nobody does continuous assessment. Nobody evaluates anybody if they're up to date. Pathologists are not up to date with what they need to do for diagnosis. The students who are being trained are not up to date. They don't understand it. They don't know it. They don't see those cases. For them, breast cancer is rare. They've never seen it. Even when sickle cell is available in Cameroon, a lot of people get up to finishing medical school without taking care of even one patient with any of the drugs that do work. So you get to see training is a problem which we need to address. We don't want to be negative, but it's all about understanding the problems, the policy. Sename is also a big problem. And the Clinton initiative is trying to bring in oncology drugs in Cameroon. They're doing a lot of work in that sense, and maybe other biosimilars in other topics. So this is a taboo area in Cameroon. People don't want to talk about it, but there is just so many things that can be done, Elvis. And I would stop here so that we can get into question and answer.
Yeah, thanks a lot, Dr. Mono, for those remarks. I think that was very deep. The first hand that I see up is Franklin. Franklin, please, over to you. Franklin.
Yeah, thank you very much, Dr. Alain, for this excellent presentation. Yeah, I think when you talk about therapy, I don't know, maybe I stand to be corrected.
Franklin, I think we've lost you for a moment. If you're speaking, we can't hear you. Okay, I think we lost Alain. So we lost Franklin. So just give him a few minutes to reconnect, and then we can discuss. Alain, I think someone mentioned, talked a little bit in the chat about the role of Tsunami, and I wanted to hear from your perspective what the role you see the role of Tsunami is in terms of the procurement of targeted therapy. What sort of role it has kind of played in that pharmaceutical landscape in terms of connecting the government and pharmaceutical companies externally.
Yeah, thank you, Brian. I think that it's a major problem because by the name, it's the National Drug Procurement Agency, and in the last couple of years, we've really seen it's been struck by a lot of issues with scandals and stuff like that. And on a personal note, we have worked with Sename before, and nobody really understands the policy. Who gives them the essential drug list? I don't know, because usually, again, you feel that what the scientists are saying is different from what is happening on the field. The Sename has a very great role to play in access to therapy, because first of all, they are the ones that have the logistics. I was talking about biosimilars that need to be stored at a particular temperature. Sename has probably one of the biggest cold chains in the country, and they have been doing so with vaccines and all of that. I think the major problem with Sename is the fact that they don't have a very smooth relationship with pharmaceutical companies. Over the years, there's been the erosion of trust, where people are simply uninterested to provide medication, because in the past they have had problems with payments. I'll take the example of my former company, where we provided medication for, I think for a long time, Mylan was the only company that was providing HIV medication in Cameroon. Were they the only ones that could provide? No, every other person has simply stopped providing, because they had, personally, I think we had debts of millions of dollars unpaid. And so the issue we're asking ourselves, is it a procurement agency? What is the mechanism for payment of suppliers? It doesn't appear very smooth process to me. And I think that's where the real problem is. If we need to address this issue, then we should start from Sename, where we should have stringent rules about what Sename should be getting. They should be listening more from the healthcare professionals. They should be up to date with their payments. They should be strict with the contracts that they sign with wholesalers. And I think that is why we have a lot of parallel sales. We saw more than 80% of chemotherapy drugs in Cameroon today is not coming from Sename. It's a problem. We in 2019, 2020, we supplied trastuzumab to Sename. We supplied about 100 packs. Patients were so excited about it. Within 6 months, it was done. People had bought everything because people were buying their 1-year medication and stuff like that. Within 6 months, within 1 month of supply, the product was done. People were paying cash. But it took Sename about 4 years to pay the supplier. So at the end of the day, the company simply said, no, we are not doing that again. We are not doing business with Cameroon. So I think that the problem is really the trust issue that has been eroded between the Sename, where everybody is trying to do what they can in terms of maybe getting medication through private pharmacies or from other wholesalers. You have like the Cameroon Baptist Convention, which is, they're really doing a great job. They have more inventory at any one time than the Sename, which is shocking. And so I think that if we need to fight this battle, we need more policy implication at the level of Sename to be able to address some of these issues. And I've mentioned the role of the patient advocacy groups. They are the ones. I'm not trying to instigate anything, but I think I've seen the way things work. If they were going to do a public demonstration and say we are cancer patients, we lack medication, I think the next day a communique is going to be coming out. Patients need to understand that they have to. We are in a system where everything needs to be seized. Nothing is given. Patients need to come together. It's for their interest to be able to push for some of this policy change.
Thank you, Alain. Franklin, over to you.
Yeah, I'm so sorry, my computer was programmed to restart and I didn't take notes. Yeah, thank you once more again, Alain, for the great presentation. So my question was based on the fact that we know genetic aspect of the patient, maybe socio-demographic and maybe nutrition can play a great role in therapy. And based on Cameroon context, which the population is very diverse and dynamic, is there any immunomonitoring platform in Cameroon that can determine this medication, their efficiency to this different patient population, and maybe what could be some of the possible results that we are getting so far? Then talking about the novelty of the therapy, and I don't know when this starts, what do you think has improved in terms of novelty with respect to what was previously existing there, especially in Cameroon, where we know the context. So what is really new in terms of this in the context of Cameroon? Thank you.
Yeah, thank you for the question. I think that there is, despite all the chaos, I should say, there is progress, but this progress is really driven by individual initiatives. We've seen a lot of private laboratories that, you know, do IRC. They get the sample, they send it out of the country. It usually takes a week or two while the patient waits. People know that this is important, but in terms of local initiatives, I don't know. Personally, I don't understand why we can't do ISC in Cameroon. I don't understand. Maybe I'm too narrow-minded, but I think these are things that can be done. Imagine an ISC. ISCs are very kind of affordable based on the use. I think that it's not only in oncology like we have seen. It cuts across. We have in rheumatology, in dermatology, ISC can be used. And even if the government or private entity was supposed to invest in that, I think the return on investment is going to be top-notch. Answering your question directly, again, a lot of private initiatives have been made, a lot of private provision of medication, but mainstream, I don't know of any initiative. Dr. Mono was talking about the child that is having initiatives to improve access, but I'm not quite versed about that. But I imagine it must be very recent because I'm not aware about that. Dr. Mono, you might help me on this.
Yeah, so in terms of just Maloba's question, understanding Cameroon and Africans as a whole in terms of our phenotypic variation, it's something which even the American Society of Oncology and Hematology and many other societies, even the FDA, is prioritizing studying Black people because we know there's a big genetic variant. And the only way you can get that done in African countries is encouraging clinical trials and encouraging us participating in creating an environment where we'll be involved when these drugs are being developed. And also, as Alain stated, put ourselves at the phase 4 level of trials where drugs come in, we're able to monitor and do surveillance and see exactly how we performed in areas where these drugs were tested. And Alain's presentation is just the tip of the iceberg about things that are tested, because there is really, if you go into the detail, targeted therapies are quite vast and different. And we test for different targets. We test for different things. Immunotherapy is a bit slightly different. CAR T cells, bispecifics, those are all different things. And so we need to be involved when these trials are done and create a good environment. And then the second part of the question about investment back home, I've asked this question myself. It's really about the people who are in charge of some of these hospitals and some of these places. I cannot imagine La Quintini. I'll give you an example with La Quintini. I don't understand a hospital with that level of capacity and those level of patients in Douala, with people in our economic capital where there is money, and L'Hôpital General, why can't they sit together and get a pathology department that can run an IAC? Why must it be sent to Centre Pasteur? These are questions that are very fundamental. And if these hospitals are actually ideal centers where they want to become reference centers in our country to treat cancer or treat anything, you cannot even do any diagnosis in nephrology without getting immunohistochemistry standings and getting other things even. So these are platforms that would help everyone, and you can create actually what I call centers of references back home in Cameroon. These are things that we need to think about. Cameroon is, we as they always say, is which kind of dance they say, we do 2 steps ahead, 3 steps behind. It's 2 steps ahead. I've forgotten the country that they call the Bafia dance, where we do 3. So if you go back to the 70s, you'll be very surprised. If I had a professor who told me the concept of how CHU was created, cardiac surgeries were done in CHU in the 70s. You will not even know that. But today we are doing some in Cameroon and we're advertising it. So we are back in the 70s in many things. Our pathology lab, where I trained in, when I did clinical pathology back home, we had huge automated machines that were there since the 80s and 70s. They are not working. Those were automated machines that were created when CSU was built. So we have a problem of sustainability. We have a problem of having the right leaders. We have a problem of championing certain things. I'm happy the Cameroon Cancer Society, last year, their topic was actually IAC, breast cancer. After we made a lot of noise, they also adopted it as their topic. As IAC, I could not understand how people treat breast cancer without knowing that. And those who tested it in Cameroon at the time was less than 10% of patients from all papers. That is fundamental. So it just goes to show we're taking a case study, but there are other diseases we cannot diagnose and treat like this. So Maloba is a complex question. It's a question of people taking responsibility. It's a thing of even the director of La Cantine can start today. If I was a director, I know how much I've run hospitals in Cameroon, can do that. And he's going to make profit out of it because it's expensive. They are sending it to France. They are sending it to Centre Pasteur. Centre Pasteur is sending some of those tests to France. They're sending it to the US. Bingo does it in the US. There is smaller healthcare system. Maybe they may want to get it done internally. They're already improving a lot of things in Bingo. There are good stories also in Cameroon. The Baptist Mission is a very good story in Cameroon. As Alain said, they have more inventory in cancer medications than any other hospital in Cameroon. That's a fact. They have better infrastructure in order to give chemotherapy. I mean, they have training. They have the only, L'Hôpital Général, the other day I saw on LinkedIn, trying to get knowledge and teach their nurses about palliative care and morphine. Bingo has been giving morphine since I left medical school. I knew Bingo was giving morphine since I left medical school in the early 2000s. And Bingo has been doing that for years. Why could they not learn the palliative care, even the supportive care teams in our hospitals? We have a problem, even access to pain medications back home for these cancer patients and other patients. So it's a problem that crosses across the board. And Alain explained all the problems very well. Now we need to become advocates. As he said, cancer treatment changed when Ugandans marched during the HIV conference in Uganda and they put dead patients on the streets. The War AIDS Day and the rest of the world saw it. Nobody could not see it. So they came for the War AIDS Day. They brought out all sick patients who were dying of HIV and the patients allowed themselves to be put on the streets. The rest of the world saw how the pandemic left from a 1980 pandemic that started in California or was born there, and it's now an African problem, and we had to subsidize these medications. We did not have a choice. The world did not have a choice. Our consciences were shocked. Everyone's conscience was shocked. BBC could not avoid it. CNN could not avoid it. Those who were living in their different crypts in different places in the world saw it, and they understood the plight of Africa and those in South African countries at the time. Maybe we need to do this.
Thanks. Thanks a lot, Mona. I totally share your sentiments as well. I know Michelle asked a question in the chat, and Alain, I'd like to hear your thoughts about why the pharmaceutical industries are not investing in biosimilars production. I don't know if Amel, you'll be willing to unmute. I not want to put you on the spotlight, but Amel Edwi is a pharmacist in Cameroon. She trained in Cameroon and has had other trainings in other places. But so you're familiar with the pharmaceutical sectors in Cameroon. Be really curious to hear about what your experience has been in terms of what the key challenges are and what are some ways that you think some of those disconnects that exist between government infrastructure and the pharmaceutical sector and also the scientific community, how we can sort of bridge some of those existing gaps. Amel, over to you, if you can unmute. Okay, I think Amel hasn't I think she's not, probably she has not gotten me, but Alain, what are your thoughts on the investment in biosimilar production in Cameroon? And I see that Dr. Samuel mentioned about return on investment, but I'm curious what your thoughts are.
Yeah, I mean, I agree about return on investment, but I don't think that our problem right now is where the medication is where we are right now. It's not about where the medication are made, but how available they are. And the decision to invest in a place is, of course, it's driven by the need. If there is a need for it and they see that it's cheaper or cost effective to produce it on site, then they are going to do that. But I think that beyond that, the major issue again is the barriers that are there for some of these companies that want to invest. People are willing to invest, but they simply don't know how to get into the market. We have a lot of policy restrictions. We have a lot of things going on, and it just frustrates any potential buyer. And in terms of the environment itself, we have people that need to be trained. It's a lot of investment to to think of biosimilars. And again, personally, I think that we should be more concerned about having these biosimilars now. It's the onus of these companies to say, oh, these people have been ordering this medication. I think it's more cost effective for us to just build a site where it's being consumed. So that it's a difficult question to answer from the perspective of a patient or an African, but it's at the company's discretion to decide where to build an infrastructure based on the need.
Yeah, thanks a lot for mentioning that. And another question that came in the chat from Matt Polo, I hope I'm pronouncing your name right. She brought up this issue about other interesting models that in Africa, where she mentioned the Remicade. I don't know, Matt, if you'll be willing to tell us a little bit more about this project in Nigeria and how they are trying to resolve this. You mentioned connecting Rocher and the Pharma in Nigeria. So have you seen interesting models in Africa that you think Cameroon can potentially replicate in terms of countries in Africa, in sub-Saharan Africa, that are doing this right, that you think we can copy, we can potentially copy from? Interesting models that you think Cameroon can potentially learn from?
I'm new in this forum. I saw the advertisement on LinkedIn, so I'm really glad that I saw it and I was able to attend. Thank you, Dr. Abeh, for the excellent presentation. In terms of what is being done in Nigeria, there has been two, I think, successful cases of pharma and also patient organization. One is the radio project, which was initiated by Pharma and Roche. Is basically what somebody alluded to earlier. How do we know that those personalized medicine will probably give a benefit to patients? So basically what they did is, with the Abuja hospital, they basically looked at HER2 positive breast cancer patients, and Pharma was in this case the payer. So they were arranging the financial payments for patients who were positive for HER2. And they had a deal with Roche. Roche is actually one of the drug makers for some of the immunotherapy in breast cancers. And they were able actually to source the product from Roche directly to those patients with a payment plan, which was, of course, powered by Pharma. Pharma is a Ghanaian company, an access company in Ghana. And I think they're now in Kenya and other countries as well, and I think in Gabon. And the other one was about the, I think it was the partnership with, it's not a partnership, this is a commercial, and I should say I'm also a medical science liaison, but with Johnson & Johnson, or Janssen now. That's how I know about this one. We basically actually were able to bring Remicade to Nigeria. And this is based I agree with the need, but also with how we're going to get repaid. And if we have a road, at least the pharma company have a road for getting the payment, and there is a need, those are the two things that they need to go for it. Even if there is barrier for Nigeria, fortunately, there were many barriers that were already down when we got there. But last year we were able to get those immunotherapy, at least for the Remicade one for rheumatology patients there. But this is again a partnership where we work with insurance company and then also the main hospital seeing those patients. So I think this type of thing can come to Cameroon, and I have a sense that this is not going to come for the government. In those deals, it was not coming from the government. Is the payers, basically, who's paying for this. The insurance company can see there's a benefit for them to basically reduce the cost that they're paying for long-term care or for just medication that are not working. And they can see there's a benefit to talk directly to the company. So those two things, the need and how the company actually is recouping its money. Those two things have to be there, and they will work out the barrier. There are a lot of barriers, but I think if there's a financial incentive beyond just the is there a need? Everybody agrees there is one, but they are commercial entities, and they need to see how they're going to make money. So those were my thoughts.
Thanks a lot, Matt, and also thanks for joining us today. It's really great to hear that that over Akin Gold, it's really the Cameroon and in particular, and I think many other sub-Saharan Africa have this huge challenge, and we've discussed at length here in the town hall how the epidemiological landscape is changing across the continent. And we really need to find ourselves in a way where we are well positioned to deal with this epidemiological transition that's occurring in Africa. So thanks a lot for sharing that, and also thanks for your work. And you mentioned with Johnson & Johnson. So thanks a lot for sharing those perspectives as well. Alain, I'm just curious if you had any remarks or comments. She talked about some very interesting models from Kenya and Ghana. I was wondering if you had some thoughts about those other interesting, seemingly successful financial models that are in other African countries. Alain.
Yeah, again, it really just boils down to who is really willing to do what. She mentioned about the fact that the government was not implicated in this. And maybe we should start looking at a model where the government is not implicated. Maybe we need to look at people that are interested in seeing a change, take the forefront of this and not rely on government. But then it's on the flip side, it's complicated because it's the government that needs to issue some of these marketing authorizations. It's the government that needs to that's running some of these programs that they say is free of charge. I really, having worked in Cameroon, there are things that I saw that I found really interesting. For example, in the molecule that I mentioned to you, trastuzumab, which we provided to Cameroon in 2019, 2020, we provided it to them. For example, I'm making this up for $100. And then when the official prices came out, we saw a big announcement. The government has subsidized this medication, and right now we are selling it at $125. The initial cost was $100, but they are subsidizing it, and it's becoming more expensive. And then this is the government, where they probably don't need to pay taxes on the product. They don't need to pay extra costs for logistics and all of that. So I think we really have a problem. And these are some of the things that really stops potential investors from getting into the market, because it is chaos. Nobody wants to put their money where they are not sure of getting it. You see patients paying from out of pocket. Government programs are collecting the money, but they are not paying the wholesalers. That is a big problem. And I think that maybe if we need to really look into practical ways of going around this, we have to look at public or private initiatives like the partnership which Mark mentioned, with Roche. I think Roche is probably it was probably with Herceptin, because they are the originators of Herceptin. Those are some of the initiatives. We have tried, we tried an initiative with hepatitis. It failed in Cameroon. We lost almost like $300,000 on medication that was brought and then got expired, and then we had to pay more money to destroy it when patients were there dying of hepatitis C. So it's a problem. We did the same project in Burkina Faso. We did the same in Ivory Coast. We did it in Tanzania, which I was personally implicated in all of this. Cameroon was the only place where it failed. And it was, on a personal note, it was a shame to me, because it's like, okay, you live in Cameroon, you're doing these things elsewhere. What is going on? And I'm like, I don't know. I think we should just halt everything in Cameroon right now and figure out what's going on. We have, for example, a big issue with stock taking. We have hepatitis B. Patients are, we know that hepatitis B patients, if they don't die, then they have to be taking this medication at least all through. But how do we get into cases of stock out with a medication that is constant? It's not like patients take it for 3 months, like the hepatitis C. Patients are taking this medication all through. We don't have a system where we have a cohort of 3,000 patients, and so we should, at any one time, we need to ensure that we have a stock that is going to take us 6 months. Nobody ensures that. Then when you have stock outs, people start getting into panic modes. Where am I getting this medication? Where am I? It's a whole lot of things. And maybe we have to get into private partnership to be able to make a change.
Yeah.
Yeah, Elvis,
Thanks, Brian. And I think the example that Alain made of which really was touching, is the fact that as a vendor can actually supply medication, and money is collected from patients, and the vendor is not paid, despite the fact that patients actually paid for the medication. That's really a clear situation of a dysfunctional system, right? The example that Martha gave is a very good example of how the private sector can drive and this kind of change. And in the cancer space, like Mono mentioned, the CHAI has been advocating for such a model, and I think CHAI got inspired by what is happening in Nigeria. In Nigeria, there is an organization, not for any advertisement, but called EMG Resources, and they are a digital company, but that is dealing with supply chain, and they've signed deals with some states in Nigeria, and what they do is they are powered by the government to get this medication from the manufacturer at a deal, right, for the country. But the government, understanding its complexity of passing through the government, empowers this agency to be able to use their digital health platform and manage the supply chain to all the hospitals. So they know that the medication comes in, there's a revolving fund. The medication comes in, it goes to the different hospitals. At any point in time, they know which hospital is selling what number of the medication. And at the end of the day, the resources gets back, and EMG Resources is able to reorder the stock based on the uptake. And it's really working. At any point in time, they can know this hospital has sold this number of tablets, and the funds are put in a unique account that EMG at any time can know how much is there and how much they need to send back to the manufacturer. And so based on this, we had a conversation, and we invited, the CEO of the company. It's actually an American-based company, but they are Nigerians, and they are trying to do this work back in their country. And they have actually sent an MOU to the Ministry of Health in Cameroon to see how they could help bring their expertise to manage, start with cancer medication in Cameroon. And I think that those are like the kind of good examples that we can get, not from abroad or from some other foreign Western country, but even from a neighboring country that is trying to do a similar thing. And I have the privilege to know the CEO, and I think we are meeting in a fortnight. to see how maybe this kind of conversation can be, really given some more attention, even if it means us as a town hall using our voice to empower such initiative to take place. It starts with cancer medication. It can go further to hepatitis, meds, and others. But one of the things I think is really deep is supply chain management. It's just so poor in the country. At any point in time, no one knows what quantity of medication is available in stock that can be used for what period of time. Because they're still using the kind of rudimentary method of supply chain management. We have tools, we have digital platform, we have technologies to use to manage supply chain now. And I think that is really important. And Alain, you mentioned something about incentive. Like what is really interesting is that in as much as some pharmaceutical companies might be burned out because of the fact that the payment is not regular and that there is trust, and I can agree with you 100% that there's been a mistrust. Sename has lost trust with so many vendors. In fact, right now, when they put up public tenders for medication, people don't go in. Like they put up a tender that they want to buy a medication and nobody is coming to buy a tender. I've never seen that happen anywhere. Contractors are always eager to go in for any tender anywhere, but that's the only agency in the country that when they put up a tender, nobody goes there. That's just to show you that some trust has been broken. But Alain, I had also another experience where I've met pharmaceutical companies who are actually refusing to enter into the African market because the thing is not their niche market. For example, and I would cite this, I met with a company, I don't want to cite the name of the company, I met with the director of global population health, and they produce a very important medication that helps to slow progression for chronic kidney disease. And we're trying to talk about the fact that we have an initiative of screening for chronic kidney disease globally. And I was leading the initiative for Africa population-based screening program. So our thought was, how can we get this company to get this product available so that as we screen patients, as those who can afford can actually get this medication to slow disease progression. But they're simply like, their niche market was Asia, maybe Brazil, India. Africa was really not their market. And the question I want to ask you is, apart from maybe the financials, what could be some of those things that could be a barrier for some of those companies that are manufacturing these drugs that they think that maybe Africa is not their niche, not because of the epidemiology or that maybe we lack the disease? What do you think could be some of the barriers maybe out of what you've already mentioned?
Okay, thank you for the question. And there is just one answer. You have already given the answer. The simple answer is the economic model, which is not sustainable. One thing we always have the tendency of forgetting is pharmaceutical companies are businesses. They are not charities. And they have investors. The CEOs have an obligation to provide results, because at the end of the day, at the end of the year, investors shareholders sit down and the CEO has to present to the board and say, okay, we made dividends of $100 last year, and this year we have made a dividend of $110. That is all they care to hear about. They don't care where you are selling the medication. They don't care what you did. They don't care who you laid off. You have the obligation of results for them. And so the single most important driving factor is the economics, the money. If they don't want to come to Africa, then all of these barriers that we have put are making them unable to come to Africa, because they see that they're going to take a longer time, maybe 3 years, to invest in Africa, and they are going to be maybe getting the fruits maybe 3 years later. No guarantees. But then if I invest in Asia, it has a system that is working, and I can hope that next year I can tell my shareholders that, okay, I made this investment Q1 of this year, Q2 of next year, we are hoping to get results. In Africa, we don't have that. I give a practical example of my previous company that supplied a medication as important as HIV medication, and almost like so many millions of dollars. It took them 6 years. How does the CEO go and explain to the board and say, we are expecting this money? That's not your business. You are not effective. They're going to fire you. So when they tell you that it's not a niche for them, it means that they it's not profitable, as simple as that. Matt, I don't know if you have a different perspective on this, being in the field as well.
Thank you. I agree fully, 100%. They are businesses, and the CEO do whatever he can to keep his position. I will just add that also reputational risk. I've seen that some products have been killed because they think either it's going to cannibalize, or if something goes wrong. I'm not going to say names. There was at the time a really good product that was actually being developed, and another company was also having the same product being developed, and we heard that they might be heart, cardiac arrest and things. They just shut it down, and it was in a certain regions in the globe, and there was a reason. We figured out why, but they just shut it down. In Africa, you have the epidemiologic risk, you have infectious diseases. It's not well defined how those drugs might work in this context. So you have an additional risk. That's what the population where those drugs are typically tested, right? And this discussion, they won't say it, but if they feel like it can compromise what they already have, like in the European, the Asian, or the North American market, then they're not gonna go there, for sure.
Oh, that's interesting.
Yeah, thanks a lot, Matt, and thanks. Dr. Sama, you mentioned quite a few. I'm just wondering your thoughts in terms of solutions, sustainable solutions for the future. When you think about this topic, and we've discussed a little bit about the challenges with, the loss of why the pharmaceuticals don't have interest in investment, but wondering your thoughts around what are when you think about this subject and the problem, that there's clearly a need and there's definitely an issue. I'm curious what you think might be a sustainable solution for the future.
Thank you, Brian. I think you must have seen, Alain, thank you again for the excellent presentation, and Matt, your contribution. Looking from this side, we already know that like I mentioned, it's all about the economics, the return on investment. But if we look at our supply chain in Cameroon, and then what the town hall is doing, because we know that there are potential private investors that would love to probably engage. And the advocacy, and in terms of policy, I think Alain mentioned that. And I think that some of the things that we can do in the town hall and also other groups is how do we continue to network with the government? And like Elvis is saying, the EMG that Elvis is talking about, if we can have such strategy and also contacting the ministry, having networking, especially through the town hall and other groups, and of course, Alain mentioned about those connection, especially like with the CBC. There are many other private organizations that we can team up with, connecting with them, and also now getting the government to be able, because those authorizations will still have to come to the government. I mean, we are in the field, there is a lot. As he was doing the presentation, I think Mono and I, we've talked about sickle cell. He mentioned about the challenges. Like you have Sename, we have almost 200 patients that they need this medication. We have challenges having access to those medications. So through private organization and having a group that is also in touch with the government, maybe through the town hall, there are many of us here, many organizations that would love to invest, but how do they get connected? Sometimes the lack of information is so huge for those private investors that actually want to do something. And I believe that, I hope with the working group at some point, some fruits will come out of that. And if that really works, this is something Elvis that we'll probably need, because there's a lot that we discuss here. And in my head, in my mind, as a business person, just like Alain is saying, I'm thinking about the practicality. I'm thinking about that. How is it going to help a patient? How is it going to help a business that is on the ground? How is it going to help Alain, as he was saying, when you go back, the CEO goes back. That word I use, return on investment, on both sides. Each side, the patient is looking like, am I getting my medication? Is the access available? So that is where, as we work as the town hall and many advocacy group, it is to be able to reach to the government, do something in order to encourage. I know that Dr. Ngachu is also, Professor Ngachu is on here, and he will also attest to you the challenges that he is facing. So the key will be, I believe the minister also, we are doing a lot, but the key to your answer will be that improving on our supply chain. That will be very helpful. That if a company back home wants to connect with Alain, connect with Matt, and they will be able to have that education and also know that this information is available. And I believe that the work that we started with the ministry, with the working group, if at the end of the day, we have that system working, it's going to solve most of this problem. There will be that connection between diaspora and our system back home. But right now, that connection, there is a big gap, there's a vacuum. Because if you didn't come to this town hall, many of us, if you ask many other companies in Cameroon, they don't even know much about Sename, because if you need medication, you don't even know who to go to. If you don't have a private connection outside, you don't really know where you are going, where will be your next source for the medication. And I believe the gap will be filled when the public health system in Cameroon have that connection with diaspora, as we're already doing. Thank you.
Yeah. Now, thank you very much, Dr. Samuel, and also thanks a lot for your work with the working group that was set by the Ministry of Health to support and create some of these problems as well. So thanks a lot for your feedback. As we round up, I just wanted to, I see we have Franklin. I'll take Iya first. Iya, if you can present yourself and then pose your question briefly, and then I'll take Maloba's question.
Okay, thank you very much. I am always interested in Town Hall, and thank you, the organizers of Town Hall. The initiative is really a one of upload. I just want to get something more. It's an interesting topic for me. I used to attend Town Hall. I am in the Netherlands, and currently I am a junior pharmacovigilance officer, and that's why it's important for me. So I wanted to ask, like, because as it was rightly said, it is a business. So I think if also there are companies in Cameroon, I mean private companies who are ready, because it is only the private companies back home that can maybe manage the administrative next or administrative procedures back home. And if they prove to the companies out also that because it's actually sometimes I know there are pharmaceutical companies that you just sign, like you are not producing, you're just buying from a company, you buy, you pay your money, and then you sell. So if there are companies in Cameroon, private companies that already have looked into the market, if we can establish that, I'm also interested in investing back home. If we can establish companies that are at a certain level that can also prove to international pharma companies that they can buy, because if we want to buy, if we have our money to buy the drugs, I think they will sell. But if we know our market very well, it will be an easier way if we look at it from the business standpoint, as it was said, that we look at it like business. If they are gaining, then we can easily have a corporation. Thank you. That's my contribution.
All right, thanks a lot, Iya, and thanks a lot for contributing to the town hall as well. Franklin, I see your hand is up.
Yes, yes, yeah. I think this is an aside for Cameroon, I think all of us should vote next year. That's the best way to start changing things. Yeah, with respect to what is said here, from the discussion that Alain have mentioned, I think that if I were a cancer patient in Cameroon, I would think that I'm dying. So, Alain, what do you think if I were a cancer patient? What do you think I should do in this present situation to have hope with the context of Cameroon?
Go to church and pray.
Period. So it means that we need to believe in the
Anyway.
pastors and the medicine man.
Anyways,
Because that's the truth.
that was a joke, but I think your question is quite broad because again, it depends on so many factors. It depends on what kind of cancer it is. It depends on the logistics that are available for the cancers.
Take the worst case scenario.
Yeah.
Take the worst case scenario. So should I just believe I should be dying?
I will let Dr. Mona answer that.
Well, I think in not just cancers, but in other diseases, right? There is just enough that can be done with the resources that are available. And if you find yourself in a context where all the resources have been depleted, or maybe that they are not available, that's not a question. That's not a question that anyone can answer for you, because then it's just you're in a bad situation. You can make the best use of a bad job any way you choose to, but then I don't think anyone can have a golden answer for such a situation, right? We have many of such situations. We've seen patients who are waiting on a queue to get their dialysis and they are not able to do so, and they are dying. We've had patients who are walking long distances just to go get maybe access to emergency obstetric care, and they die. So there's so many other things that are not going on well, and it's just a very challenging thing to think there could be a golden answer for someone in that kind of situation. But
Elvis, I wanted to add something.
Yes, I will use Baloba's question to just send a message. I think it's just, I deal with cancer patients every day. And here in the US, no matter where, once you get a diagnosis of cancer, most people think they are doomed because of the perception, no matter where you are. And cancers are different. But in Cameroon and everywhere in the world, the first thing is you need to be empowered as a patient.
Yeah.
First, number one, you need to be empowered. We are in a world now that you cannot lack information. There is just so much information online that you need to be empowered, and you need to also try to get resources from where it's valid. Even if you're in Cameroon, you need to know exactly what kind of cancer. Am I having breast cancer? Are there support groups? Which hospital treats it the best? What kind of breast cancer? Because once a patient knows this information, they're going to challenge their physician or whoever is helping them. So I'm a big advocate of empowering the patient. If a patient is empowered, no matter how poor they are or where they are, they may have better care than someone who has money and is not empowered. So my advice to that patient who is in Cameroon, who is diagnosed with cancer, is try to know more about what you have. Try to know more and ask questions, and also seek help where we can get help. There are multiple, it's not always bad in Cameroon. As I always say, there is always a light at the end of the tunnel. The bingo experience to me is a big light at the end of the tunnel. They are able to help a lot of patients. They have been able to help patients seek care, not where it's popular, but where you know people have received the most adequate care. So my advice to anyone who has any kind of chronic disease is do your assignment. Cancer in particular, reach out. There are multiple experts out there. They would help you, they would guide you, and you will get the best available care possible. So I'm not going to go into dashing the way Cameroonian health system is, but you can get wonderful care even in the bad system if you're able to challenge your doctors. If you say you have breast cancer, have you done my immunohistochemistry staining? The doctor says no, then can you send it? Have you done, I have stage 2 or stage 3, have you done a CT scan to stage me before doing a mastectomy? Do I really need it? Those are questions that if patients start asking them, things will change.
Maybe not our
Part of your
doctors.
question is if they can advocate and do what we say, they should be able to, at times, go out and march for the right of this disease. Even one person starts it, you will not believe how many women will come out who had breast cancer, how many men will come out who had prostate cancer. You will not believe one person can start a movement that is going to change the way Sename does things, the way the Ministry of Health does things. By just standing in the Ministry of Health one day, in 10 days, the whole Cameroon will be there.
Mami Wata, Mami Wata.
That's not what I'm not pushing for that right now. So, but I know I've taken much time. Just my closing remarks, Elvis, to me, what I take out of this is that we should invest in infrastructure. We should invest in infrastructure, build the infrastructure that we can use. We should invest in education and training. We need to change the way we train healthcare workers overall, make them up to date with what is going on. Research and development is something we should invest in. We cannot stay, and you're doing a lot in research, regulation and framework, we are lacking in all of that. Public-private partnership is what is winning in multiple places. Access to diagnosis in all these diseases is lacking. Then we need to also negotiate for affordability, health insurance, awareness and advocacy, and international collaboration. To me, those are the things that are key. So thank you. I don't want to take the mic anymore.
No, thanks a lot, Pharma, for mentioning that. I think those are very salient and key points. I just wanted also round, since we're past the time, and thanks a lot. I think this was a very, very insightful discussion. Maybe take the closing remark, maybe take some last comments from Dr. Samuel, whose hand was up. And also I'd like to invite Matt as well. Love to hear about your closing thoughts as well. Samuel, maybe we'll start with you.
Thank you. I wanted to reiterate the point that Alain mentioned at the beginning about doctors saying we have tried everything. I think encouraging our practitioners about referral. We have a case actually in DUP where we've been trying to work with the regional hospital in Bamenda, the district hospital, and you will find out that sometimes the practitioner will feel like if they are referring patient or trying to seek for help, it's almost like they don't know. And I think I'm bringing this in connection to Franklin's question, and as Mona is talking about empowering patients, also we need to encourage our practitioners to know that they can reach out. They can reach out to their colleagues. They can reach out to find information before you make that final decision of just saying we have done everything. I think that will also be a beginning of learning where you have a limit. So that's all I wanted to add. Thank you.
Yeah, thanks a lot, Dr. Samuel. And Matt, any closing thoughts and remarks? And would love to hear about your experience as well, probably in some future town session. Would love to hear about your experience working with Johnson & Johnson and some ways in which those kinds of collaborations and partnerships can be built in Cameroon in particular. Any closing thoughts or remarks regarding this discussion? Matt?
Thank you. Well, thank you for having me. I think it was a very pleasant and also insightful exchange. The only thing it's really, I want to thank Dr. Alain Abeh because he spoke about his experience. I think one closing thought is really, it leaves me with hope. I think someone mentioned if he is a cancer patient in Cameroon, what option does it have? I think there is a lot of hope in this forum. Dr. Alain mentioned about the pleasant experience he had with other African countries, like in Burkina Faso. I think there is a lot of learning lessons there about the enablers. How can we break down those barriers? Because we are all Africans, even though we may be Cameroonians. If we can take a look at what has been positive in those other African experiences and try to see how we can just personalize it and move forward in Cameroon, I think that's where I think we can start moving forward. And there is hope. That's all I can say. Thank you.
Yeah, thanks a lot, Matt, and thanks for joining. There's just one last person I wanted to call, Professor Ngachu, who is also a member of the working group that was set by the Minister of Health to help with some of these issues. Professor Ngachu, I don't know if you're able to unmute yourself for any closing thoughts or remarks regarding this topic. Professor Ngachu.
Thanks very much, Dr. Tigomo. Thank you very much, Dr. Alain. I think your presentation was an excellent presentation, and it highlights some of the issues that we face back in Africa and particularly in Cameroon. You know, there's a lot of talking about things not working in Cameroon. And as Dr. Samuel says, we are trying to see how we can foster the partnership with the Ministry of Health. In my humble experience, which is very limited, my understanding is that there's a lot of attrition in the Cameroon population, that they struggle to deliver what is actually written on paper. And if we are trying to push things to happen in Cameroon, we should actually try to get people to actually do what is written on paper to do, because the policies in Cameroon are all there, but executing those policies is the biggest challenge. Thank you.
That's such a powerful conclusion. Thanks a lot, and thanks a lot everyone for joining, and thanks again to Alain. I think this has provoked a lot of thoughts, a lot of discussion regarding what the future might be. So I would like to give you, Alain, maybe some closing thoughts and remarks. I think you've heard different perspectives from different people throughout these discussions. I'm just wondering what your key takeaways and your closing remarks are, Alain.
Okay, thank you, Tegumo. I think I've spoken about everything, but just to conclude, I want to say that I'm very passionate about access to medication in Africa. And I've been having discussions with people to see the best ways. I mean, understanding the challenges that are there now, talking with a few of my contacts within the industry to see what best can be done. And there's some progress. I'm having a few meetings in the next couple of weeks to look at possibilities. Within my company, I'm meeting the business development team. They have some very interesting products. We are in conversation with a few countries in West Africa, including Cameroon. I hope that we get the access to be able to do a few things, especially in rheumatology, dermatology, ophthalmology. We have some very great products from out of the company, and I'm hoping that something can come out from it. And it's going to be my wish that, you know, at least one of these products can go through, and then people can have access to this medication. It can spark up, like you said, other discussions on, can we do more with a model that has already worked? So again, I'm very passionate about it, and I'm happy that everyone found the conversation interesting. Thank you.
Thank you. Ellis, over to you, and maybe you can help us.
Yeah, thank you very much, Brian, for excellent moderation. It's always a pleasure to co-moderate with you. Thank you, everyone, for joining us. We meet here every fortnight to have this kind of conversation. So please join us in 2 weeks' time for yet another very interesting topic, which we shall announce to you. Thank you very much once again, Dr. Alain, and thank you, Matt, for really adding your thoughts to this session. I hope to meet both of you maybe in another private meeting just to see how the town hall could be of help in just nurturing some of your ideas and tabling it to the right quarters to see what little impact it can make to our public health system. So once again, thank you, ladies and gentlemen, and I wish you a very nice weekend and see you in a fortnight.